Morning, colleagues. I hope you can all hear me and see me, but more importantly, see the slide. For today's Open Disclosure Webinar, I'm Ellie Southgate. I'm the National Open Disclosure Manager, and you're very welcome to today's webinar, Falling in Love with Wicked Problems, Utilizing Human-Centered Design to Address Complex Healthcare Challenges. So the focus of the webinar today, as it suggests, is on human-centered design and how co-design and co-development can positively benefit both those using and working in our health and care services. Thanks. So, as we will be starting in a few moments, we do want to run through some housekeeping notes. These are exactly as you'd expect and have seen from our webinars previously and from other webinars. We ask our attendees that they use the chat box if they have questions throughout the webinar, as all attendees will remain muted throughout. And please use that chat box to introduce yourself and, as I say, add your questions there, and we do have a question and answer session at the end. Thank you. Of course, we all have varying levels of accessibility, connectivity. So there are other channels through which you can access the webinar today. Sometimes we find our colleagues find that both the video and the audio being streamed through WebEx can be problematic. So you might want to make use of your phone if you have one available to dial in using the details here. These details will be shared in the chat box throughout the course, this early part, I should say, of the webinar. So throughout the course of the webinar, if you have any problems, you'll find these details in the chat box throughout. Thank you. Our webinars are always the CPD accredited, but in this circumstance that today we find we are yet to have that confirmed for the RCPI points. NIMBY points will be available. This only applies if you are attending the webinar live today or logging on live today. If you're watching back via YouTube, that is not available. And you can attain those accreditation points by emailing our National Open Disclosure Office inbox after the webinar. Thank you. Our Open Disclosure Office has been called Small but Mighty, we are, as you see here on this particular slide, Kelly is our fantastic behind the scenes today. Behind the scenes person, but she's a very experienced trainer and educator. Roisin, our general manager, will be comparing the Q&A at the end, and we're led very ably by our Assistant National Director, Lorraine Schwanberg, who will also be part of the speaking panel today. Thank you. We are very delighted and very grateful to be assisted and supported in our webinar by our two ISL interpreters. We're very grateful for your time. Thank you, Leah Murray and Orla McCabe. Equally, we'll be offering the closed captions support service with this webinar, and again, details of that will be in the chat box should you need that particular function. Thank you. And so it just remains for me to introduce today's presenters. We have Carolina Skemas, who is a service and interaction designer, both with HSE SPARK and with St James's Hospital. Catherine Hogan, the Patient Safety Together Programme Manager of the NQPS unit that we sit in as part of the National Open Disclosure team. Dr. Eve Stanley, who is the HSE SPARK Innovation Fellow and a Specialist Registrar in Geriatric Medicine. And Lorraine, who I've already introduced before, who is the Assistant National Director of Incident Management, NIMS and Open Disclosure. And I'll hand over to our panel now. Thank you.
Thank you, Ellie. Catherine's kindly sharing the slides for me, solving one wicked problem. Thank you. So as Ellie introduced herself, our presentation today is around falling in love with a wicked problem, with wicked problems and focusing on human-centered design. We were introduced into this kind of sphere, I suppose maybe 18 months ago, and we've definitely been on a journey, and we're very grateful to be accompanied by our designers today and experts from Spark who supported us with this piece of work. Next slide, please. So this is what we're going to be speaking to you about today. We've done our little welcome. We're going to talk to you about our wicked problem and how we got introduced to human-centered design. Eve's going to speak a bit more about the SPARK Innovation Programme and going to provide an introduction to design thinking. Caroline is going to speak to that and give her expertise in that area, and we're going to speak a bit more about where we're at with our wicked problem, what we've learned, and Catherine's going to take us through that and some of the concepts that have been introduced to us, and we're going to touch on some of the challenges as well, and then touch on what our next steps are. So stay tuned for the entire session. It was really a very positive experience. So as Ellie introduced us, well, before I speak a bit more about our journey, we have a little task for you. I know you've been busy entering your names, but Kelly's going to share a little poll with you. And our question to you is, have you participated on any design-led projects before? As far as you're aware, have you been involved in any design-led projects? Just a simple yes or no. You can pop that into the chat. And I'll tell you about our introduction to it now, and then we might look at the results before we move on to the next slide. So I think it was probably around 18 months ago, maybe a little bit longer. Within our own team, we obviously developed this platform, Patient Safety Together, which was launched in 2023, and hopefully you are all quite familiar with it, which is a kind of vehicle for sharing learning. I'll speak to that a little bit more. Kind of sat within the incident realm because it was focused on sharing learning from incidents. But a number of us joined a webinar, a SPARK webinar, where Trevor Vaughns spoke. He is a public service design lead and very much an expert in the field. And it was just a very inspirational presentation and webinar, and it was a bit of a light bulb moment for us in terms of maybe looking at some of our challenges, in particular that learning from incident piece, and linking in and reaching out to the SPARK program and working with designers and innovators to maybe get us to think a little bit differently, like how do we get that learning to the front line. So initially,
sorry, Lorraine, to interrupt you. There was just a technical issue with the poll, so it's just opened up again. If people don't mind just responding. Thanks.
Thanks, Kelly. Thank you. I'm glad you're here holding my hand through it in the virtual sense. Thanks for flagging that. So please do share your experience, whether or not you have been involved in a design-led project. Our first introduction was working with SPARK and with some designers, in particular looking at our national safety alerts, how they were designed, presented, were they very user-friendly for our staff, where we can issue these national safety alerts. And we worked with Dr. Rachel McNamara, who's a SPARK fellow, was SPARK fellow at the time and a registrar in public health medicine, and Linda Klotzbach, who's a service and interaction designer, and working for Matter Transformation. And they really helped us redesign and reshape our national safety alerts, and we're quite fortunate the project even won some awards and so forth. So we felt we were on the right track, and ever since then we have worked very closely with the SPARK program, who've been really supportive with our work and our kind of objective in terms of getting learning to the front line. So that's how we came to collaborate, and we might move on to the next slide. So while we honed in on the national safety alerts initially, it was really one piece of the puzzle in terms of how we want to get learning to the front line. Our journey has continued. And as many of you working in quality and safety or working in the health or social care setting know, area we work in is complex. There are incidents that do happen, and they do provide an opportunity for learning. So we know that our staff, and there's a lot of energy put into learning from incidents, so even at a local level, and you'll all have strategies for sharing learning. You have this rich resource of incident insight, incident data. You would be producing some resources and means of sharing learning following some analysis within our own team, within patient safety together. We develop safety supplements and safety alerts. I'll show you those in a few minutes. And we have a number of means of cascading that. We have a website page. We have a push system where how we push the alert out to hospitals and services. And we have various means of cascading this shared learning. The key question for us remains, is that learning reaching the right people? Is that learning where a lot of people invest a lot of time in terms of reaching that learning, is it getting to the right people? And as we all know, a lot of even our patient partners and patients and those who are involved in incidents, the key ask from them and the challenge they put to us, they don't want this to happen again. They want people to learn from their experience and to prevent such incidents again. So this was our wicked problem that we've been working on over the last little while, making sure that learning from incidents and other safety sources reach the frontline, very busy frontline workforce. I might move on to the next slide. So some of these pieces you'll be familiar with. So these are some of the kind of resources that we have been developing over the last little while. So we have the national safety alerts, which are kind of high priority safety messages. And we try not to saturate the system with those because they are meant to be kind of prioritized information. Did a nice piece of work with our patient partners to complement them with some patient information around the safety alerts and design an infographic to accompany the alerts. We have a spotlight series where we share some focus on learning from other organizations and shine a spotlight on that and share that. We have patient safety supplements that provide more of a narrative resource and discuss a particular safety issue or safety risk. Again, signposting staff to information and highlighting some of the risks around it. We're very grateful for the Patient Safety Digest and the work that the HSE Library do in supporting us in developing these on a quarterly basis, where we highlight any recently published journals, articles that focus on the topic of patient safety, open disclosure, human factors. And these are all resources that you can bring to your teams. And that was kind of the vision behind some of these resources. The next slide. And then we also publish patient and staff patient safety stories. So again, they can take a different format and something that we're very keen on. So if you have any ideas or suggestions in terms of some stories or any of the other topics to look at, then do contact us on Patient Safety Together. And we do have a patient safety community, which is a community for staff working and interested in quality and safety. And we have regular virtual events where we invite some external speakers in that. Next slide, please. Okay, and I'm going to hand over to Eve at this point. Thank you.
Thanks, Lorraine. So it's my job today to kind of introduce HSE SPARK to you and to explain, I suppose, what we do and how we do it and why we do it. So first of all, sorry, will you go back to the preceding slide? Sorry, Catherine. First of all, HSE SPARK is an internal entity within the HSE, and it's an innovation programme. And what it sets out to be is many things to many people. So from one perspective, we're a funding stream for projects. We are an education support from a design thinking and innovation perspective. But also what our main job really is to empower and to build ownership within the HSE to the frontline clinicians who we believe have the solutions or have the ability to find the solutions to the everyday problems that they come across in the system. So next slide. Thanks, Catherine. So everyone loves a good origin story, and where Spark came from was that in 2017, NCHDs, so non-consultant hospital doctors, felt that they had no agency due to the kind of transient nature of their jobs, that they would move from site to site, and felt that they had no agency to transform or change the healthcare system in which they were working. So they went to the National Doctors in Training and Planning office, and there was then kind of HSE Spark was born, with the first National NCHD Innovation Fellow. And then in 2019, our fantastic colleagues in the Office of Nursing and Midwifery Services Directorship came on board. We had a Nursing Midwifery Fellow at that point. And in 2020, the health and social care professions came on board also, with a representation of the 26 professions under the HSEP umbrella. In 2023, then we moved under the Office of the CCO, which gave a real, I think, bolstering to the clinical work that we do, and also to the frontline clinicians that we are interacting with every day, and also gave us a really good, I suppose, perspective and strategic vision about what was happening across the country, both nationally and now regionally. Next slide, thanks. So our objectives within HSE Spark are, number one, to support HSE healthcare staff to engage in innovation and empower them to make positive new changes within the health service. And we do this really through promoting, celebrating initiative and creativity, and really pushing collaboration between different specialities and disciplines. We at Spark feel that frontline staff are best placed to identify key challenges faced by service users and care providers, and our unique bottom-up approach empowers clinical staff to develop solutions to those challenges. And what we want to do is to create a work environment that is innovation friendly, where innovation becomes the norm, and where innovative practices become an easy, I suppose, or almost a utility for people to use and be able to deflect to. Lastly, we want to develop systematic capability through opportunities for innovators within the healthcare service by educating in design thinking, encouraging user-informed development, and supporting projects through funding, network, and key design tools. Next slide, thanks, Catherine. So the initiatives that we offer are briefly outlined here, just their names. So Spark Seed is our kind of entry level microfunding stream, and we offer funding within this up to €5,000. This involves an obligatory, I suppose, experience in design thinking workshop with Martin Ryan, who is a design lecturer within the NCAD. He's also an author and an inventor, and he gives a fantastic online design thinking workshop into the basic principles of design thinking and how to use those principles to tackle the problem or the challenge in your healthcare setting. And then you have to pitch to us, and it's a really fantastic process actually. Spark Impact then is our larger funding initiative and stream, and that's up to €90,000. And that can be used with other funding initiatives within the HSE, such as the Consultant Innovation Fund. And this again is looking at a bigger project that is more novel, new, kind of what might be a system change or step change in current practice. And then lastly, Spark Ignite is our initiative for intrapreneurship within the HSE. And what that does is that gives, I suppose, an opportunity to HSE employees to validate, to kind of look at the market potential of commercially viable, products or projects that they're looking at. and to get expert guidance. And we've previously collaborated with HIHI, and that has been really useful for people, and that's a funding of up to €5,000 for that. Next slide. Thanks, Catherine. So it's my job again to introduce design, and the way that we kind of look at design, I think, from a society perspective, is that it's a technical skill and it's focused on how a product looks and feels. And traditional design disciplines are kind of, product design, graphic design, and then fashion design. Human-centered design or service design that we're going to talk to you about today in relation to healthcare. Next slide, thanks, Catherine. Is really about building empathy. And what we mean by that is that the service designers that we use within HSE SPARK, and design is really embedded very heavily within our ethos. The reason being is that we feel that when you design looking at a particular problem or challenge for the user, with the user, and in the user's environment, you're doing that through empathy building. And when you ground you're examining the problem in empathy, it makes a solution that is iterative and really sustainable, because you're taking all of the kind of, the people who are using that service or that system into account, and making sure that solution works for all of them. And as you can see here, what empathy does is it helps define a problem further, and you learn more about the users through testing. And through this testing, it creates new ideas for the project, which leads to maybe a prototype, which sparks a new idea. And then the testing reveals insights that redefine the problem. So like I said, it's a really iterative process that goes further and further into the issue. And like I said, develop something that is truly sustainable and can be embedded very easily. Next slide, thanks, Catherine. So we're very lucky in Ireland, Lorraine alluded to it earlier, that Trevor Vaugh is part of the design within the public services. And this has been an initiative within all public services where human-centered design has been brought in to tackle the most complex problems that we have in our society today. And these principles were laid out, and this is a published document. And what it really does is it makes things, person-centered, but user-centered in particular. So the principle one is that we will put people first. We will design to be inclusive. We will design services together, and we will design for trust. So they also design so that knowledge can be reused and shared. And challenging assumptions is a really important thing, and I think something that we all are guilty of in healthcare and in public service. And what they like to do is design from the top down and the bottom up. And they want to design to deliver value in all its forms. And like I said, they're designing and building to test, learn, and iterate, and really to make things simpler. Next slide, thanks, Catherine. So I really love this, and Carolina will talk about this a little bit further, but the one thing I really love about this is that top line is about firstly designing the right things and then going on to designing things right. So in order to design the right things, you do that through empathizing, so understanding the challenge and talking and observing people where they are, by defining that problem and that challenge really well, and then ideating. And then that's when you just start to design things right. So what you build is a prototype, which are low-cost experiments to test users, learn and evaluate the assumptions, and then iterate. So you're applying changes in response to learnings and continuously optimizing and improving. So next slide, thanks. So I'm going to give you some examples of a couple of different projects where we've used human-centered design to address challenges, both very, very big and apparently minor, but make a huge, huge impact to a service. So this very brief case study is about the ophthalmology department in the Mater Hospital. So this is not my work, this is the work done by Mater Transformation. And what they found, so their healthcare challenge, was that the ophthalmology department was divided across a number of separate buildings, and it was obviously, aimed at an older cohort of patients or service users who have a significant, impairment in their vision. And the problem is that a lot of patients or service users were arriving to their appointments either late or not arriving at all, and they were extremely distressed. They were expressing this unmet need by not knowing where to go and how to get there within the hospital setting. And also staff were coming to the department saying that they were spending a lot of time helping these patients or service users to get to the right clinic or room that they were required to go to. So Mater Transformation used service designers to come and examine this problem. And this wicked problem really began to show its complexity when they started examining the signage that was there. So, even in this small screen, you can see there the ophthalmology sign has the smallest font, and thank you. And you can see here, this was the eye emergency department, which was full of cluttered signs and posters. And then lastly, this is an example of the letter that used to go out to patients. And these were the directions. So the diabetic renal or retinal treatment program, off the link corridor, glass windows in brackets, old radiology, uplift of eye department. So I certainly wouldn't be able to decipher that. I can't imagine what it was like for patients or service users trying to navigate that. So what they did is, through building empathy, so service designers came in and they mimicked the different, visual impairments that the majority of, the patients using the service would have. And what they found is, with these visual impairments, mimicked, they couldn't actually make out the wording on the signage there because the contrast wasn't enough. They weren't able to find out where the different areas were. And so through this empathy building, they were able to eventually, through a long, arduous process, so next slide, please, to build signage that was accessible with really good contrast and almost branding that became consistent throughout the hospital. And then using, very obvious visible cues for the patients using the services as to where the ophthalmology areas were. And this led to a huge improvement in people who were late for their appointments. Next slide. Previously, they had surveyed and examined and observed how people found the service, and 39% prior to this implemented solution found it difficult or very difficult to find. And this led to a reduction to 2%, and 89% of people felt relaxed or happy on arrival. And this was one very brief but very telling quote from a patient that said it was spot on. So I think that's a real marker of success. Thanks, Catherine. So the next service design project that we have worked with are the Mama Hubs. And these are based, the first one was based in St. Luke's General Hospital, Carl Kilkenny. And what Mama stands for is minding you and me always. So the Mama postnatal hubs are a groundbreaking kind of multidisciplinary team new service developed for new mums and their partners. And the challenge in this was that, this is their wicked problem, was that there was a physical and emotional challenge that women face in the first few weeks and months after having a baby. And I think this quote that they uncovered when they were doing their initial discovery kind of tells it all, is that it's kind of all about you at the start, but as soon as that baby comes out, and even though you've had a major operation, you are definitely forgotten about or definitely not a priority, and it's just all about the baby. And through significant research by Hannon et al., they found that there was a massive unmet need from new mothers or who had just given birth. And really what came from this discovery was that, and the empathy building, I suppose, before that they went into the solution, was that women wanted somewhere to go, someone to ask, and someone who asks. And that was a really powerful, I suppose, call to action, and really a brief for the project totally, for them to know exactly what women wanted when it came to this. And I don't just mean women, I mean women and their partners. So next slide, please. Thanks, Catherine. So what they developed was, like I said, a community-based multidisciplinary service for women in the postnatal period, in a place where they could go to talk to someone, with experts there within the postnatal care kind of realm, not siloed but all together. And then what they did is they connected new mums in a networking fashion. They developed a service menu so that every new mum who came to the service could look at what was, this menu that they could pick, what they think they needed. And also they set up a social media service so that new mums, day or night, whether they were up in the middle of the night feeding and having problems, could contact the service and leave either an Instagram message or contact a midwife who was on in the hub that day. Next slide. What the design interventions led to is that they developed these resources as well, so that they could give, firstly, this green one here to partners as to what to do in the days and months and weeks after having a baby, as a support to the partners of the women who had their baby. And then this was given to the mothers, this yellow one. So a kind of a calling card or a point of contact to ask someone or someone who asks them. And then also a feedback postcard. So this was received really phenomenally and made such a huge difference to the initial mothers who were using it, that it's now being scaled to 5 different hubs nationally. Next slide. And really, I suppose what I want to let you know today is that we can't all be designers, unfortunately, as much and all as I'd love to be one, but we can all have a design mindset, and that's what we're hoping that you will have by the end of today, just a little bit. So with that in mind, I'm going to hand you over to Carolina Skemas, who is our service interaction designer, and she's going to talk you through that process. Thank you.
Thank you, Eve, and hello, everyone. So my part is going to be a little bit more informal. So I don't know if we can ask Kelly to kind of bring up the results of the survey to see the survey, sorry, the little poll that we did to see, to have a sense of, like, I would say the room, but like the digital room of who participated in design-led projects before or who didn't. So I don't know if we have that available for now or if we have a look at that after. I think I'm just going to ask Catherine to move on to the next slide so I can start to talk about a little bit of the history, the timeline of design and etc. And then we can have a look at the poll after that, or whenever Kelly's ready in the background there. So just to kind of move back a few steps from the amazing examples that Eve gave, it's kind of like, but where does design actually start, and how that all kind of becomes a thing? And I think that to kind of just pin a date, it's around the 1960s. It's when kind of technology started to be more embedded into like our everyday practice, such as like how we call the digital revolution more or less started. And in the 1960s, in that kind of place in between engineering and digital, the term wicked problem was coined. And then there was a further kind of, let's say, keeping developing all throughout the early 2000s. But basically around the 1990s, Stanford design school kind of came across, and they became like a big name in kind of, let's say, putting design as a practice out there, because it's kind of a new field, new profession, more or less, if we can put it like this, considering, you know, that things have been existing much longer, especially when we're talking about healthcare. And then it came with IDEO as well, that is like a big name in design. And like, again, design applies to all type of industries. We're not talking about healthcare here now. And then, like, just to kind of pin that as well, like in terms of healthcare, Mayo Clinic, it was one of the pioneers in embedding design on their, let's say, everyday practice of delivering healthcare services. And up to today, they have over 100 designers embedded in their everyday practice. So, Catherine, if you can move on to the next slide, please. So then, just to talk about like design again, from that kind of first slide that Eve give the example of the traditional, when we think about design and we think about the traditional design methodologies, we're always thinking more about products and like tangible things. And the design that we talk about here, it's more design methods for problem solving. So it's an approach to innovation. So that's why SPARK Innovation Program kind of, let's say, appropriated from that kind of design methods, design thinking, the human-centered design approach to promote innovation through empathy, understanding, and creativity. So the design methods, they aim to make sense of those wicked problems that are often complicated by human needs and behaviors, which I'm sure that you guys are very familiar with the concept of human factors. And the designers, like so people like me, we will use different tools and methods to help us understand this kind of, let's say, problem space, as we call, and use different methods to ideate, conceptualize, and iterate on potential solutions that I'm going to talk you through a little bit more in the next few slides. So there's a few different, let's say, evolved design disciplines that kind of came across after digital became such a big reality, which we're still talking about product design, physical and digital products. And then we have interaction design that is more, that is often related to digital products. And then we have service design that is like an approach to end-to-end systems that sometimes will encompass those digital and physical products as well. But I'm going to talk about this in the next few slides. So there you can see the design the squiggle that is kind of often used to refer to wicked problem. And then when we're talking about wicked problems, like the definition of it is a social or cultural problem that is difficult or impossible to solve because of its complex and interconnected nature. A problem where there is little agreement on the definition of the issue, which I think that healthcare people are very familiar to that kind of concept, especially because it's not always straightforward, as you can see in the first diagram there. It's not a simple solution from A to B, or like if the toaster is broken, you're going to look for the problem. The problem is the dial, you fix, and then the problem is fixed. It's a little bit more complex, as you can see in the diagram there. So it's like you need to look at our organization or our service within an organization, not as a individual, like as a siloed little place, but as part of a bigger ecosystem that interconnects with other things. So in the next slide, please, Catherine. It kind of, and everything starts with that purpose that defines the direction of this action. So it all starts with kind of that piece that Eve had kind of touched on, which is the empathy. So it's very good that we have like a direction of action. So where do we want to go? In this example, how can we achieve healthy senior citizens, and kind of put all those, let's say, different agencies and stakeholders, interest holders, providers, all this kind of bigger picture of the environment to move towards that kind of goal, which we do have that, as you can see, on the designing our public services, and as well as in the person-centered approach, which I think it's very common from a healthcare perspective as well. So Catherine, if you can please move to the next slide. So sometimes that can be a little bit challenging, especially because there's a tendency for organizations to start to revolve around their internal goals. So it's common often that like within that kind of, let's say, environment or that service, we have everything kind of going fine. But in the end of the day, if we don't look to that kind of broader perspective, we might leave service users wondering what's happening, because sometimes the problem is not within that place, but it's how do people get there to access the service and get their problem addressed or resolved. You know, sometimes there's not a way to resolve 100%, but at least address that problem. So if you can please move on to the next slide. And this is kind of a very simple diagram that I do love to use to exemplify that, which is basically we use those kind of design tools to kind of create those circles and map it out what happens in each of those organizations and bodies and services to understand where are those intersections of, let's say, common goals and let's say things that maybe one place cannot address and the other one can, etc. So we can find those intersections through design methods, and then we can have a clear vision on how to collaborate together, as you can see in the second image there, on like how can we make those services work together and collaborate and hold hands in order to deliver that bigger picture. So if you can please move on to the next slide. So as you can see there, again, that kind of squiggle of representation of the wicked problem that starts very complex and complicated, and how kind of going through those, let's say, through that design process that you've seen exemplified in different ways, but it kind of all talks about that kind of same kind of, let's say, stages that starts with understanding, observing, defining a point of view, so like defining a problem, and then you move on to developing ideas, then you move on to prototyping those ideas, and then testing those ideas to then move into implementation, which will be kind of that end, let's say, solution space, let's put like that. And this is another approach to, let's say, the design process that is a little bit more, let's say, structure, and is the double diamond approach. That again, there is a lot of overlap with that kind of classic 5 to 7 steps of the design process, which starts with empathy, and then you move on to insight, idea generation, and then you gain a clear definition of that problem, and then you're able to move on to that ideation, prototyping, testing, iteration, and come to an end. So as you can see, it's like a very diverge, converge process, and at each stage of that kind of, let's say, phase, that there's again no formula, there's no one size fits all. Each project and each problem space would require different design methods and a different, let's say, approach to it. So it can vary, like we start in the beginning trying to understand and kind of really diverge from that initial problem, which is through stakeholder maps, ecosystem maps, competitive review, so understand what's happening out there, like what has been done. And then there's ethnographic interviews, and that would go for everyone involved on that. There's some contextual inquiry that sometimes is just observation, because there's a lot of difference in between when you ask somebody to recall how do they do a process in a step, like a step by step, and then how they actually do. So there's all those kind of tools that help us, let's say, build a bigger picture of that initial problem, again, on that divergent fashion. And then there's also like the UX audit and quantitative surveys. So basically it's a very big approach that consider biopsychosocial aspects of a service, and also like the macro and micro environments where a service or a product sits within. And then we really diverge from that to then go back into that convergence of definition. And then we start to use some more specific design methods tools. So we start to develop personas through empathy maps. Then we start to develop user journey maps, kind of mapping that current state Then there's the study of the current information architecture, and then experience maps, and there's so many others. So then based on that, we can gain a very basic laser focused view of what problem are we trying to solve, and we gain a definition. So therefore we can then move on to the multiple ways that kind of, let's say, redefined through information problem becomes. And then you can start to kind of, let's say, ideate on that and generate the ideas, but informed by a much broader perspective of that problem, with sketches, whiteboarding, paper prototypes, then again, a revision, information architecture where that is relevant, digital wireframes if that involves a digital product. And then based on that, let's say, low fidelity prototyping. When we talk about prototyping, it's not getting how the final product will look like, but it's a way of communicating those ideas so those ideas can be tested in the most efficient way as possible, because at this stage we're looking for quantity so we can refine them into quality. And that's when we move on to the prototyping phase. That's when we get validation, and we can evaluate those ideas and gain feedback to then implement those ideas into kind of what will be looking more like a solution, or like addressing that kind of initial problem, but in a way that has taken a lot more into consideration all those, let's say, steps. So if we can move on to the next slide, please, Catherine. So then to just kind of talk a little bit about the service design aspect of things, to kind of, let's say, tie in the knots together of everything that I kind of spoke so far. When we talk about service design, that's kind of my area of expertise, and we talk about users, we are not only talking about that kind of end users. On that example that I use, healthy senior citizens, we're also talking about family members, caregivers, members of the wider society. We're also talking about all those providers, so all the health and social care professionals that are delivering that service and those touch points. I'm going to touch about this a little bit further, but just to give an example of that, it usually requires like the end user to interact with the service provider. In a simple example, it's like thinking about a GP visit, and then there is usually interaction with the product or a system, or maybe sometimes both, or maybe sometimes, depending on that GP practice, they might not have digital booking system. It might be you talk to the secretary, and in the background they will organize the appointment for you. So I hope that kind of had given an idea of what service design is. It's quite untangible, and I hope that I can give a little bit more tangibility over the next slides. But basically, service design looks into all the moving parts of that. And it's, of course, informed by some basic principles that you're going to see. It's very similar to those 10 principles that were outlined in the Designing Our Public Services, that is highly informed by the design practices. So I'm just bringing there some examples of literature in service design principles, but basically the key principles is that they are user-centered, so person-centered, but in this case, not only the person receiving the service, but everybody involved into delivering that. It's co-creative, so it includes all relevant stakeholders or interest holders in the design process to make sure everyone's voice is aired, and therefore all the pain points for those users are addressed with said solution. Also, it's sequencing, so it breaks a complex service into kind of, let's say, small chunks, so it's easier to be, let's say, processed. Again, it's evidencing, so it looks for a little bit of tangibility to kind of build trust to that service and brands, and it's holistic. So it's designed to kind of address all touch points into, let's say, that journey, even if we're talking about that example of going to a GP, which is quite simple. So Catherine, if you move on to the next slide, please. This is an example of a service blueprint that I think it would be very similar to kind of a diagram or like a process flow, but a lot more detailed because it takes into consideration all the front end and the back end activities. So when we're talking about a service and a blueprint, I like to give the example of going to a theater play. So it's not only about that kind of point when you go into the theater and you watch the actors delivering that play, but it's when you consider everything from the stage design, light design, how do the people get to hear about that play? How do the people buy the tickets to go to the play? And what needs to be happening in the background at the same time in order for the people to be sitting down and watching the actors deliver that service? So it has those kind of vital parts of a service encounter, which is usually actors, location, props, associates, and processes. So it's kind of very, very complex, and mapping those out, it really helps us drive insight and again understand how can we eat an elephant, which is usually by chunks. We're not going to try to swallow a whole elephant. So it does really help us to map that out and then define how we're going to tackle those, let's say, smaller pieces. So if you can pass on to the next slide. So just kind of to wrap this up into kind of the things that Eve already said and kind of how those design methods would apply at each stage, it's very important that we challenge of our assumptions to gain the definition of the problem from a user's perspective. So that would give us the clarity that we're designing the right things to begin with. So what is really the problem? Who is that a problem for? Who else has that problem, and then what has been tried before. There is a lot of knowledge in that within itself to help us move on to the next stage. And to the next slide as well, please, Catherine, which is when we are able to move on to that next phase, which is designing things right. So once we have make sure that we're designing the right things, we can then design them right. So that's when we kind of move on to that kind of more tangible piece of co-design, and we have all those interest holders in mind, including the final users as well. So it's a really well defined by the user needs, and we can start to develop prototypes and test to learn and then adapt, so that we can finally come into a final solution. So I think that would be my end of slides. I think, Catherine, if you can move on to the next slide, and I think I will hand back to Catherine. That will talk about their specific design journey. I'm not sure if we are ready to maybe have a look at the poll results or if we're going to keep to the end.
No,
but I'm going to
put it into the chat. It is there as an option on the poll, but I'll pop it into the chat as well as a percentage, just in case that makes more sense. I'll pop it in here now for everyone.
That's super. That's super. So yes, just as the poll results, 25% of the audience has participated on design-led projects before. As a designer, needless to say, I'm delighted to hear that 25%. It's a big increase from, let's say, 2 years ago when I started to work with Spark, and 75% not. So I'm really hoping that today is going to inspire you all to kind of look into taking a design-led approach to things and work with my fellow designers. And on that note, I will pass you on to Catherine to talk about their own design journey. Thank you so much.
Thank you, Carolina. And I suppose we're going to just finish up the session today, kind of just talking you through how we used all those design principles and concepts in our own project that addressed that wicked problem that Lorraine referred to at the start, where we have all this patient safety learning, but how are we making sure that it's getting to the right people? So we had identified that we had an issue, and Lorraine has kind of outlined that we have an existing relationship with Spark, which has been fantastic. And as a result, we put in for some funding with Q and the Healthcare Foundation in the UK for some grant funding, and they give funding, have been given funding for member-led collaborative improvement projects. So we were very lucky in that once we applied for this funding, there were over 180 projects that applied for funding. We were the only project from the Republic of Ireland to get funding for 2025, which was great. And the title of the project was Patient Safety Learning, Reaching the Right People for Action. And we decided from the outset that we were going to use a human-centered design approach to tackling this. So we developed a project team, and you can see from the membership there, it representative of people who both use and work in our service, in our healthcare services, with an interest in the design approach and with an interest in our problem and fixing it. And we also then worked with, we're very lucky to work with Context Studio, and Context Studio are a people-centered design company, consultancy company, I suppose, that specialise in the public sector. They're based in Dublin. They have done work with a number of public services, including Dublin City Council, the National Museum. They also worked on the most recent HSE app as well. So they were very much, I suppose, au fait with the working within the HSE and what we were trying to achieve. So our project brief really was to explore the experiences and the realities of HSE staff in accessing and applying learning. And we're all aware that most people that are providing frontline care don't routinely sit by a computer, may not have a phone or an email, but yes, there's a lot of information that we're trying to get out there that's very, very relevant to that cohort of people. So the methodology we used, as I said, it was very much based in those concepts and principles that Eve and Carolina have gone through with us. And we started with a North Star workshop, and that was where we got a number of people together, again, representative of all the different cohorts of staff and people that use our health services, to come together to kind of start out on our journey. And straight away we were hit with a challenge when we started what we thought was going to be the very simple task of stakeholder mapping, and we started with like who is this project relevant to, and you know the big hitters came up about the staff working in hospitals, and all of a sudden it was growing and growing, and we were gone out as far as agency staff. We were looking at people came in on contractual work. So really at the end of the stakeholder mapping we realized that anybody that has anything to do with healthcare is involved in patient safety. So really, we really needed to kind of redefine that further, and as a group decide on the cohort of staff that we were going to work with, and the different services we were going to work with. So we did that very democratically, looking at the different options and a few rounds of voting to make sure that we felt the group of people that we were going to work with was representative of who we thought was important for the project. Once that was decided, so we decided on 3 clinical settings. We worked with a community residential nursing unit. We worked with a NICPOP, which is an integrated care program for older persons, and we also worked with a large emergency department in a large teaching hospital. We did 19 semi-structured interviews. I'm saying it was very much led by the experts in the area, and Context Studio did a lot of the heavy lifting on that, but a number of the project team also went along to the site visits and used a lot of those tools that Carolina went through in terms of that on-site observation. And then we did, again, as a project team, came back together to work on that co-design and prototype planning. The co-design workshop was a great day. A number of us were able to come together, the project team and other members of SPARK, and again, people that we felt would be able to provide some really good insight and some value to our thinking. And the goal of that workshop really was to take what had come through in all the qualitative interviews, the observation studies, the North Star workshop, and really kind of to come together and figure out some ideas of how we were going to move this on to actual design and some prototypes. So you can see from the picture there was a lot of interactive working, there was a lot of brainstorming. At the end of the day, there were close to 250 individual ideas that came up in response to our design challenge, and it was a small enough group that came up with that. I mean, there's a few pictures of a few of us there, but I think at max there might have been 16 people at it. So it was fantastic that when we start from how might we question, that we came up with so many. Now some of them were off the wall ideas, but that was, I suppose, the fun in it as well. We were to take from the mundane to the absolute bizarre and try and figure out how we might go about fixing our problem. So what we learned from a lot of that information, methodology, interviews, the visits, the workshop, was, I suppose, 7 different ideas, and really that One of the most encouraging findings of the study was the depth of commitment in patient safety that exists in our services, and that was very, very clear from when from day one. Really, it's already woven into day-to-day clinical culture, but it can be highly localized and it can be person dependent. It is seen as part of the job of everyone's job, and it's seen as part of kind of, you know, it's delivered in a formal way through shift handovers, safety pauses, safety huddles, but it's often informal. So, you know, sharing tips at bedsides, and for those of us that have worked on the front line, you know, again, this is day to day, so it's not going to be news to anybody. Like, you know, you're talking with your colleague, you're sharing tips, whether it's on antibiotics or medication management, you're flagging issues as you're going along. If you see a problem with maybe a medical device, or if you observe maybe an incorrect technique for manual handling, you know, that informal sharing of learning is always there. There was a low awareness of the utilisation of patient safety together, which we weren't that surprised on either. There is evidence that patient safety together resources are reaching the front line, and people have seen or are aware of the individual national patient safety alerts that have gone out, or some of the patient safety supplements, but they didn't realise where they were coming from. And as a result of that, really, a lot of the resources that Lorraine spoke about earlier are remaining untapped. So people don't know that the digest or the spotlight or this patient safety stories are available for people to access freely, and they're available on that website. So that came through quite strongly as well. Using the right channel for the right information was another concept that we looked at, another idea that we looked at, or what we learned. And again, we all know that information moves through a variety of channels across our healthcare system. Each has its own advantage and disadvantage. You know, we looked at handover meetings, huddles, there's emails, notice boards, ward diaries featured very predominantly and had a high confidence rate associated with them, where people knew they were going to get the information that was very, very relevant to them. A lot of people are using the internet. A significant amount of people are using WhatsApp groups within their own services, and then phone calls, bleeps, checklists, etc. So there is that information cascade that's there, but again, it's very dependent on the staff group that you work in, where you're working, and again, can be localized and person dependent. And then we have the issue of communication saturation. So information overload is being experienced by many. A lot of people are feeling overwhelmed really about that carpet bombing of communication, and feeling that it dilutes the impact of critical information that they really need to get to. And it's a recurring frustration amongst people, the sheer volume of messages that are competing for attention. Alongside the fact that people may be sharing desktops, there's now two-factor identification logins, so emails are being blocked from, say, even from a virtual perspective. In the more physical sense, you know, there's overfilled notice boards. We've all seen those notice boards where they're 2 and 3 thick, where information on it is out of date with a number of years. Posters are laying on top of one another, so people become blind to that information being shared. And Eve kind of even flagged that in the example from the Mater, where the doors into the eye emergency department, you know, had a lot of information on it, and as a result, people weren't able to see what they needed to see. We have fragmented technology. I suppose that's not a surprise to anybody either. It's uneven, and it creates inequity amongst those that are searching information, you know, from very, very good availability of desktops and access to information, to people using shared desktops, not having access to any internet. And again, often it's dependent on availability of Wi-Fi or different accessibility issues. So that often and regularly impacts how people are accessing learning. There are varied learning styles, and we all know that, and that's a personal preference for people. Both in learning styles and often in training delivery modes, and that can vary significantly amongst individuals. And then the last thing that we learned was about that safeguarding of in-house knowledge, which I suppose, due to the nature of our health system, we use a rotating and temporary staff cohort, and that on top of staff turnover and shift rotation and reliance on agency staff can often leave newcomers blind to new learning, past alerts. So I suppose, you know, a lot of this is probably very evident for those that are working on the front line, and you can see that happening in real time, but it was really useful to come together and look at it from a design perspective. So that would enable us to look at those the learning, look at the ideas and develop some concepts. So one of the concepts I'm going to share with you today that has evolved from our project, and I suppose we are very much in that kind of testing stage at the moment. So we're going to just share one of the concepts with you, just to give you an idea from how using a design approach in these concepts can look and what you can do with it. So one of the concept that has come up is really focusing in on patient safety together and making kind of an attention grabber brand campaign out there. And, you know, hadn't seen us, and we're looking at this since 2023 or whatever, around patient safety together, and we'd often shorten it to PST. But we never saw it as a type of kind of onomatopoeic quality that came up in one of our in our workshops, that it might work as a branding attention grabber option to run a campaign. And to leverage that to kind of get people interested and make it a little bit fun, and kind of to use that branding to work to get that information out there. And again, when you're coming up with your concepts, as you can see here for the number 2, number 4, and number 1, you're looking at tying that back to our learning, so that awareness of PST2 ties in with the low awareness and utilization of patient safety together. The communication saturation obviously ties in with that learning, and the culture of patients of safety and learning ties in with that point number 1 that's there as well. So we're flagging this also as kind of a way, as a kind of for yourselves to keep an eye. Hopefully we will be working on something in the next few months that it will be coming your way to kind of build that attention around. But I suppose the important thing to reiterate really is that the design doesn't stop once you get to this stage, that the design thinking and the design approach will continue into this part of it. So even as we're now building this new, all the different concepts and working on them, we're using the design approach in all the different phases. And that is the really, I suppose, encouraging and piece around it, is that while a concept might seem really, really large to start with, that you break it up and you start really, really small, and you phase out your approach to testing it and implementing it. So for example, in the campaign, you'd start with a micro pilot and you'd do an A/B test. Now I had to check as a non-designer and nothing to do with it what was referred to as an A/B test, but really it's here kind of figuring out with a very, very small group, which would you prefer, A or B? So which would you prefer? Would you prefer this design or would you prefer this design? And using that to test a number of ideas and concepts. And you test that core hypothesis with a really, really small group of people. And then you know, from an action perspective, you might draft a mini style guide, you might reformat the next resources to use that branding, and maybe just a 2-question micro survey. Did it catch your attention? Who issued it? And then measure it. And again, measurement is always important to make sure that you are making the changes for the good and not just for the sake of change. So you're looking at the percentage of respondents correctly identifying that this information is coming from Patient Safety Together, and building up the trust and the confidence within patient safety together. There's always challenges and risks for everything, and it's really, really important that you know, when you're using that design approach, that you're aware of any brand rules in this instance. So we must make sure that we align with HSE communication, HSE brand rules, that we will be using a small sample size for phase 1, and it's not perceived as marketing fluff or too cutesy. And again, then you go on to phase 2, you make it bigger, you build it higher. It's an iterative approach. You're constantly building on it. You're getting your feedback, and you're with a plan for national rollout and governance at phase 3. So that's kind of an idea of our next steps, I suppose. And in terms of what we need to do, we're going to look at all those different concepts that we worked on together, that we agreed on together as part of the project team and as part of with insight from Context Studios. We're going to look at all those different concepts that they have given us. We will link in with the right people, test them, and see we can take to the next stage and next phase and implement them that way. I'm going to pass back to Eve now, who's just going to take you through the next steps around the broader design approach. design thinking approach?
Thanks, Catherine. So I suppose our next steps really are about just making sure that, it's been clear from the presentation about the design process and what that means. And, like when we were trying to meet the brief of the project, we wanted to make sure that the concepts were built on the learnings that came from the discovery, and that the concepts that are going to be made into prototypes are iterative, just like Catherine and Carolina and I have said already, that, service design doesn't believe that services are static, it believes that they're dynamic. And so through that kind of iterative process, you're constantly going back to make sure that you're meeting the needs of both the service users and the service providers. And like we've kind of mentioned many times, there is a real partnership between the caregiver and the people receiving care, because one cannot exist without the other, and one's needs cannot be put ahead of the other, because in order for a design to work really well, it needs to take all those voices and experiences into account. The takeaway message that we want you to take from today is maybe to inspire you to explore design a little bit further through some of the maybe offerings that Spark has, but even through some of the things we've talked about, maybe might spur you on to read something or listen to a podcast about design, or even to think about some of the steps we spoke about already. If you have a healthcare challenge that you're looking at addressing, and I think everyone here is very much au fait and understands quality improvement in the processes. There's lots of synergies between human-centered design and quality improvement. And it's just another modality to look at what we feel really builds that understanding of the experience of the person who is either providing the service or using the service. So thank you so much for your time, and we're happy to answer any questions.
Great. Thanks so much, Eve. Lorraine, did you want to come in there?
Oh, no, sorry. I thought we were just going to the question section. Sorry.
Okay, no bother. Thanks so much, everybody, for joining us today. We're delighted to see that we have had over 300 live participants, and we know that some of you are joining in groups as well. So fantastic to see so many of you here to learn more about human-centered design thinking and the Patient Safety Together project. And thanks very much to our speakers, Carolina, Eve, and Catherine and Lorraine. So we do wish to go to our Q&A session now. We have a couple of questions in the chat. Firstly, if I could pose this question to Eve to start off with, because I think it's very specific to Spark. There's actually two there for you, Eve. First from Angela, has the ophthalmology wayfinding design been rolled out to any other eye departments nationally that you're aware of?
Not that I'm aware of. We have worked on a couple of other wayfinding projects through human-centered design. I know there was one in CUH in Cork University Hospital, which again was a slightly different problem, but again, no less complex or problematic for that area. But no, to my knowledge, it hasn't been rolled out, but it's definitely something that I think could be scaled very easily. The problem is because everywhere is so siloed and everyone has different signage and different, I suppose, agendas they need to meet and hit, that it becomes a little bit trickier, but I think it is something that could be scaled very easily.
Yeah, that's fantastic. And again, using other approaches, and you referenced them, Eve, yourself, quality improvement, and others like lean and implementation.
Exactly.
We look at the scale and the spread, so hopefully that potential will roll out. And if Angela or anybody else on this webinar is interested in learning more about that, we can signpost you to more information on that specific project. And Eve, coming back to you again, there was a question in from Veronica. Does Spark work nationally with the National Simulation Office or any other simulation labs as part of their work?
Yeah, so we would work very closely actually with the National Simulation Office. We'd have supported some projects previously, like both kind of in collaboration with each other, or certain projects that we would have kind of added that human-centered design piece to it, but mostly kind of from that innovation side as well, that the simulation
piece would either be leading to some kind of innovative new service or educational tool that would help patient care. But yes, we have, is the short answer. And we continue to have those very strong links with the National Simulation Office.
Fantastic. And from us, from our perspective in the National Open Disclosure Office, our Open Disclosure face-to-face skills training workshop uses role play to replicate the user experience, both the staff as well as the patients and service users. So we would love to use some of these design thinking and simulation approaches to really enhance even the training that we deliver and that we pass on the skills for services to deliver themselves. So it's great to learn more about both of those programs. My next question, I think from Shinny, I'll turn to Carolina. Hopefully you'll be able to answer this one, and if not, I'll open it up to the panel. Shinny has asked, how do we know when and where design-led projects are happening? So is there some sort of repository for other design-led projects that we can tap into?
I don't think that that's kind of how it goes. I think it's mostly the idea is that you can start applying design lenses to your own projects. So I think that this is kind of the main idea of that. Or like if, let's say, locally where you work, you do have, let's say, a problem that can be, let's say, from a QPS initiative, or can be just something that you identify as like a process or something that can be more efficient or something that needs a bit of a tweak or a change. And then you can start to talk to your colleagues about it, being like, how do you feel about that? And then you can be like, who else do we need to get involved to kind of maybe get this problem solved? And then what does our patients or our service users or their carers think about that problem? And kind of start with that kind of empathy piece. And then again, my biggest advice to you is that if you do come with a very good problem space that you think that that's common from other healthcare settings, bring to Spark, apply for a seed funding or apply for an impact funding. Or if you do have the resources internally on your setting as well, work with the design agency, or if you are even in a better position that you can hire designers to work internally with you to help you, let's say, navigate those challenges with the design lenses, then do. But like, again, there's not a project on that you kind of take on board. Is not normally something that kind of comes from your local issues, and therefore that might be someone else's problem too. And then you kind of start small. I hope that that kind of addressed the question, and I leave that open for Eve or Catherine to add anything to that as well.
Yeah, and there's an amazing array of projects that are sponsored and funded and supported by Spark. So I think that there's probably a few other design-led projects, and hopefully this webinar will be the impetus for more people to learn more about that human-centered design thinking and look at progressing their projects themselves. So maybe one day we will have a large repository of those projects that people can use for experience and inspiration. That's great. And coming to, I suppose, Catherine as well, you have a huge amount of clinical and managerial experience and improvement experience as well, and particularly working with the Q community. And for those who are not familiar with the Q community, it is a community of members across the UK and Ireland. I think there's over 6,000 members now working to improve health and social care services. It is free membership. We'll pop the link into the chat for you here. So if you're interested in applying to join the Q community, we would encourage you to do so. But Catherine, as you know, the Q community has been focused on quality improvement as an approach and methodology. And Eve, you mentioned it as well. And quality improvement and Lean and Six Sigma and implementation science, they're all proven scientific methodologies for testing and scaling improvements across services. How has human-centered design been different from the traditional QI approach in your experience?
As you mentioned, Roisin, there's so many synergies there. You know, it's just sometimes it's the same approach with different language or different different thought process around it, but it's all very much you know, centered around the person, the user, the service user, the patient, and that iterative approach. You know, I felt, you know, it's always coming through that you can't just stand still. You'll never reach the end, that you always need to kind of constantly review, evaluate, look back, and that's, I suppose, in terms of, and I see some of the queries and the comments in the chat box, is if you're new to this, it can be overwhelming. It is a lot, you know. But that's why it's so important to you know, all of us here, most of us here have an understanding of quality improvement, patient safety, all those different methodologies that you referred to. So it works really well and aligns with the service human-centered design approach. But it's so important to have the right people working with you, and like having Eve and having Carolina with us just kind of allowed us to kind of make sure that we were considering everything, considering the things that mightn't have been usual in the quality improvement approach or the lean approach, but they are so complementary of each other that they work so well together that, you know, you shouldn't be scared to pivot a little bit, to have a look at, if you feel that you have lean down or you have QI down. It has been such an eye-opener and such and personal development even for myself and anyone else I was talking to become involved with this different mindset, you know, and just to kind of challenge us again. And because sometimes you can get a little bit happy and content in your own knowledge, but this again was kind of saying, okay, didn't maybe think of that. And even the site visit that I did with the designers, that time I went to the community nursing home, the guys were seeing stuff that was just passing by me. I didn't even think it was important, you know. And likewise, Sean and Tim that I was with were saying, God, Catherine, you're seeing stuff that we wouldn't have realized was important. So it shows you the value of all the different, having the right people there, and not assuming you know everything and not assuming you know nothing.
Yeah, no, that's a really good point, Catherine. And having those new tools can often be that kind of catalyst for yourself and others to see where the change can happen. And you can triage, and the SPARK Innovation Programme is so good at you bringing the problem to the table and triaging kind of what approach might work. Eve, you were going to come in there as well. I think you might be on mute, Eve. I'm sorry.
Sorry. My own career background would be similar. Like, so QI was I was kind of living and dying by it, and I really love it. I love the methodology and how clean it is, and, you know, data driven. But when I kind of started looking at Spark and looking at human-centered design, it really challenged me personally, because I realized that I am a fixer, and so that I am very solution focused. And what human-centered design really, I think, something that kind of sets it apart a little bit more from QI and lean, is that it makes you stay in the problem for longer. So even when you're in the kind of the murkiness and how uncomfortable it is, when you're constantly finding out like what the issues are, and you're starting to uncover more issues and, you know, picking scabs in your service, it's quite a daunting thing. But really what it kicks out and what it brings you to is something that is so sustainable and so good. You know, it really takes everyone's voice and gives everyone that kind of equal kind of placing, and it's a real leveler. So that's just something that I thought, from my perspective, changed how I see things now. You know, even though I would have kind of done the same things, it's just different in that regard. It just makes you stay in
allowed to stay in the problem. I think it was fantastic. And even, you know, we gave a couple of feedback sessions to Q, and the feedback from them was that, you know, focusing on the problem was really interesting to them, and they were really supportive of us not rushing to find a solution and really exploring the problem. But yeah, as Eve said, traditionally you would have been used to trying to fix the problem, but sitting in the problem for longer is a skill you have to learn, and you almost defending while you're still sitting in the problem. But it's so rich to sit there and figure it out. You know, as you said, getting the right answer at the end and designing things right, rather than just having a solution, having the right solution.
Yeah, and I totally agree with both of you. I think rushing to solutions is nearly what we're programmed to do at this stage, you know, even particularly for people who've worked as clinicians. You want to find the answer, but sitting in that uncomfortable space of the problem can really clarify what the best solution is. Carolina, you wanted to come in as well there.
Yeah, just add my 2 cents to that, which is a very good catchy phrase that I'm sure that many people have heard already, and I think it's attributed to Einstein, where he says that if he had 1 hour to solve a problem, he would spend 55 minutes thinking of the problem and only the last 5 on the solution. So I think that that's a very good inspirational phrase that really summarizes what we were talking here in terms of like sitting and being uncomfortable with the problem and sitting on the problem space before jumping into solutions, which is something I know is very challenging for healthcare people because they're trained to respond and to solve problems there and then and not wait. So whenever you're talking about the design approaches, when you can kind of have a breather and let yourself sit and sink in with the problems of it. So I just thought that I would add that.
Brilliant. Lorraine, you wanted to come in as well. Thanks, Lorraine.
Just a mine, and the colleagues have said all the relevant points really, but what I enjoyed as well is it brought an element of fun. And you know, we're all very professional people and things like that, but it allowed you to be creative. And, you know, they got such rich insight from frontline staff, and actually our frontline staff was so creative in coming up with solutions in any case. But so that was really interesting and allowed us to kind of maybe think a bit off the wall a little bit to an extent, but brought it back to something very tangible and really impactful, we think. So I absolutely love human-centered design. I'm a complete convert to it now, and I think it's the way forward with some of the very challenging problems that we have had and faced. It's just allowing us to look at it a little bit differently.
Yeah, absolutely, Lorraine. And I think a number of the people who've attended today would agree. We've had some fantastic feedbacks. Thanks so much to our presenters today. For people that wanted access to the templates and the processes outlined, we will be sharing our slide set with all attendees, and there will be signposts within that, and we've shared some QR codes on the slides as well. So if there's anything not answered in the slides or in this presentation, drop us a note and we can signpost you to the right person. We had a few queries as well from individual projects. So again, if you want to get in touch with us after the webinar, we'll be able to signpost you, but we're very close to time now. So unfortunately, we'll have to draw to a close, and I will hand you over to Lorraine, who will finish up our slides for today. Thanks again.
Thank you, and a huge thank you from me to the speakers, to Eve and Carolina, and to the project team who've been fantastic, and just it's been so motivating, this project, because so many people have bought into it. Everyone's interested in improving and getting learning output. And a big thank you to our team from Open Disclosure as well. But I know time is tight, but I just wanted to a sad message for us, but also a very positive note. A few changes happening within our own function within QPS Incident Management, part of NQPS. Thankfully, we know that colleagues won't be going far, but I want to say a big thank you to Roisin, who has been with us as GM for Open Disclosure and has been a fantastic leader in the field. She's only been with us less than a year, but has had a huge impact on the work that we've done and has been such a wonderful colleague. While there's been a tumultuous change and developments within Open Disclosure, she was just fantastic to work with, and want to congratulate her. She's not going far, thankfully. She's taking on the role as GM in the QI NCCA side of the house of our wider team, and you can hear her passion for flow for QI there. So want to congratulate her on that slight sideways step, but not going far from us, and we look forward to continuing to work with her, and we'll miss her as our close friend and whatnot. I'm sure we'll be in touch quite a bit over the next while. Slight move as well for Catherine and Naomi, who've just done such a fantastic role in building patient safety together, right from its inception and concept, and getting it out to the masses and developing it and building patient safety together. And their success hasn't gone unnoticed. So they will be shifting slightly within NQPS as well, and sitting within Orla Healy, our National Clinical Leaders Office, so slightly moving out of the QPS IM space, but we'll still be collaborating on learning from incidents, and just want to congratulate them as well. And they've just brought so much positivity in all the work that they've done, and there's been great colleagues as well, and again within arm's reach. So slight little changes as the whole of the HSE is undergoing change, really some changes within our own directorate as well. I just wanted to say a big thank you to all those colleagues. And some of our other slight reminders, a big thank you to our ISLs. interpreters as well. Thank you for coming on today. Just a reminder about the e-learning programme again. We did issue the Q2 report recently for all the different organisations to see where they're at. You'd be reminded that we will be producing an annual report again in January and very much looking at that compliance status. So if I can encourage you to really, I suppose, shine the spotlight on that Module 1 e-learning programme. And then our e-learning programme Module 2 as well. That's maybe kind of more comprehensive training for people who are undertaking the actual open disclosure. We have quite a few new resources available for you as well. Just as a reminder, I'll have to put my glasses on, make sure I don't get it wrong. We have some promo materials so that you can raise awareness around the open disclosure policy, which was launched in June. Information leaflet for staff as well. And we have the policy implementation checklist and audit tool to help you look at, help with the implementation of the policy. Then the revised patient information leaflet is up as well, and it's an area that we will be looking to over the next little while and developing some more resources there for patients and their families. As ever, we'll be doing the Open Disclosure Themed Week, very much led by colleagues out in the system. But just to confirm the date with you, that will be between the 6th and the 12th of October this year. So we look forward to engaging with you then. Thanks everybody for coming on. Huge thank you to everyone I've already listed, and we'll see you at the next webinar. Take care. All right, Kelly. Can't close it.